Hello and welcome. My name is Joshua Korzenek. I'm the director of the Brigham and Women's Hospital Crohn's and Colitis Center, and I am delighted to give you an update and review on ulcerative colitis. Here's my disclosure slides. So ulcerative colitis and Crohn's are really diseases of modern times. When we talk about inflammatory bowel disease, we're talking about ulcerative colitis and Crohn's. They're roughly equally divided. Ulcerative colitis comes into a population before Crohn's does, and that happened in the United States with ulcerative colitis appearing first in the second half of the 19th century. And then Crohn's came in about 40 years later, reported at least first by probably Deal in Scotland, but Burl Crohn had an important hand in his landmark paper in the early 1930s describing chronic ileal inflammation and stricturing. The common etiology is considered to be a complex disease that's a combination of genetic susceptibility, changes in the microbiome, abnormal immune response, and some set of environmental triggers that may be a critical factor, and anyone who's unfortunate to have enough of these overlapping will develop the disease. This perhaps is something that would be the case for almost any of the chronic inflammatory diseases, but really I think this overemphasizes some of the parts and really underemphasizes the environmental triggers, which are critical. Genetics came along and was very exciting and interesting and provides important pathways for the understanding of pathophysiology. We're now at over 200 genes, and I think that the influence is overstated with the idea of saying finding the inflammatory bowel disease genes will lead to a cure. Probably the genetic influence accounts for only 20 to 25% of the risk of developing IBD, perhaps more strongly in Crohn's than ulcerative colitis, and the impact is relatively modest and certainly not at this point clinically helpful. When we look at IBD, there's been an impressive globalization. It used to be just diseases of the West and Western Europe and North America, but it's really become a much broader disease now. The old map really had it here in Canada, United States, and Western Europe, but it's really expanded, not just beginning to be in places like South Africa, Australia, and Japan, but really a worldwide phenomenon, and this doesn't really account for places like India that now have it quite impressively, as well as throughout South America, Eastern Europe, and Middle East. When we look at the genetic influence, this was twins in Twinsburg, Ohio. They don't have inflammatory bowel disease. We recognize that the genetic impact is relatively modest, and even among twin pairs, the influence ranges as much as 50%. If one twin has it, the other one's going to have it. Too much, less, maybe about 10 to 15%. In some studies in England of twin pairs, one having ulcerative colitis or one having Crohn's. What can we say about the environmental risk? We think there's now been a divergence between Crohn's and ulcerative colitis as we've done more. Interestingly, having an appendectomy, particularly if it's not because it's the surgeon's in there and decides to grab the appendix at the same time, but because there's inflammatory appendicitis or mesenteritis and the appendix is taken out, that if before the age of 21 will reduce the subsequent risk of developing ulcerative colitis by as much as 60%, and there are studies now looking at the impact for active disease. Other studies, relying on the Nurses' Health Study as well as others, suggest that poor sleep increases the risk of developing Crohn's, not ulcerative colitis. Low carbohydrate, intake of low carbohydrates, simple carbohydrates, increases the risk of Crohn's, and no impact on ulcerative colitis. Particularly complex carbohydrates are more important in reducing the risk of Crohn's, and low carbohydrates in that way increases the risk. Low exercise increases the risk in Crohn's, not ulcerative colitis. And depression prior to the onset of disease from the Nurses' Health Study seems to have an increased risk of Crohn's, again, not ulcerative colitis. Smoking, interestingly, has this divergence between the two diseases, where the effect is that it reduces the risk of ulcerative colitis. People who are smokers who have ulcerative colitis have a milder course than non-smokers. It also reduces the risk of pouchitis, so after a colectomy, the J pouch can be protected against the development of pouchitis with smoking. And it also reduces the risk of primary sclerosing cholangitis. What's curious about ulcerative colitis is that not only reduces the risk, is once you have quit smoking, your risk goes up higher than if you had never smoked at all. So we see a handful of people every year who decide to clean up their act. They quit smoking, they're going to get healthy, and then 6 months, 2 years, 3 years later, they develop ulcerative colitis. So it's a higher risk than if they had never smoked at all. On the other side, Crohn's disease is increased risk with smoking. It's more likely to develop Crohn's. Worsening disease course, more likely need for immune suppression, more rapid post-op recurrence after elimination of all disease activity by surgery. It's a question that's subtle, but whether there may be more of an influence on ileal disease than colonic disease. Now, why this isn't clear. There are lots of different chemicals. Nicotine's been looked at as a therapy for ulcerative colitis with really very modest, minimal to no activity, with some negative studies for nicotine enemas and others, and this sort of reduces the pro-inflammatory cytokines, suppresses macrophage activity, and there's a reduction in superoxide production, but which of those are critical are not known. Stress, certainly our patients will tell us that that's an important risk factor, and when they looked at, in a large study out of Denmark, was the loss of a child associated with a flare of ulcerative colitis or Crohn's, looking at all parents who had lost a child below the age of 17. It's hard to quantify stress, but certainly we would agree that that's probably the greatest stress anyone could deal with. And they looked to see if somebody who had IBD flared, and if somebody without IBD, did they develop it. Followed for 17 years, and there was no association with the flare or development. A curious study, but not the definitive word, and some other studies have suggested that stress, depression can be a risk for flares of the disease. Non-steroidal anti-inflammatory drugs, the consensus is that it can increase flares, increase hospitalizations, and that the selective COX-2 inhibitors are safer. Having said that, a recent meta-analysis has cast some question on this, even though this is quite standard and accepted in terms of impact on the disease. So if a patient needs some other pain medication, celecoxib, the selective COX-2 inhibitor, certainly appears to be safer in a good randomized trial for 2 weeks, people in remission. The mechanism isn't clear. It's a question of whether it's an effect on innate immune function. It reduces neutrophil microbicidal function, reduces superoxide production, it decreases mucin production, and reduces chemotaxis. So whether this is, you could argue, is a benefit, but it also clearly shows a detrimental impact. What is the role of diet in ulcerative colitis flares? Well, a high meat and sulfur diet may increase the risk. 191 patients followed with ulcerative colitis, half relapsed, which is a very high percentage. The highest third had an increased risk had increased intake of meat consumption, particularly red meat and processed meat. Sulfur intake, alcohol intake all increased the risk. I'd say that our group did a study where we just looked at people on mesalamine, 400 patients, about 12% flared, and we didn't find these associations. So it's a question, but maybe the case in that population. So when we look clinically, we tend to categorize in mild, severe, or fulminant. These are the older classifications. And what we look at really is certainly blood, a number of stools in a day, blood temperature, pulse, hemoglobin, and sed rate. Sed rate we don't use as much anymore, and it's curious that even with extremely active ulcerative colitis, the inflammatory markers that we often use can often be normal and not helpful. When we look at the endoscopic spectrum, normal, we see that crisp blood vessel pattern. As things begin to get inflamed, there's erythema. Decreased vascular pattern is one of the earliest signs that we see. Sometimes it can be fairly subtle. And friability, so just the gentle touching. The old description was with a cotton swab across the lining of the intestine causes some bleeding. Moderate, there's an absence of vascularity, there's increased friability, erosions, and then just in the more severe disease, there's ulcerations and spontaneous bleeding. When patients are initially diagnosed, as you know, with ulcerative colitis, it can be variable extent. It can be just the left side, just the rectum, and a little bit beyond proctitis or proctosigmoiditis. About half of patients at presentation present with that. Patients can have the whole left side, or pancolitis. Unlike Crohn's, which you can have skip lesions and sparing of the rectum, ulcerative colitis almost always involves the rectum, and there is then continuous involvement. In about half the cases, there's extension of disease to pancolitis. Once it gets to the ileum, though, there's usually not any disease. There can be backwash ileitis, which happens in about 10% of people with pancolitis, and usually that is not an ileitis with, as in Crohn's, with deep ulcerations, as much as more of a superficial inflammatory result, which resolves with surgery. So at presentation, about 10% or so will have fulminant disease, and a smaller subset have low activity, but most are in sort of a moderate activity, and certainly those with fulminant disease, not surprisingly, have the worst prognosis, and we need to be particularly aggressive in treating those patients. When we look at the natural history of the disease, this is slightly older data. I think we've made some impact on this, but about half will get under good control with no significant symptoms, though on medication, low activity, and about a third and about 20% have more persistent disease. Hopefully we're impacting that with our newer therapies. The colectomy rate of 30% is sometimes referred to, but really it's lower than that. It's really now, I would say, 5 to 15% in more recent studies. And keep in mind that these are systemic diseases. We think of them as just gastrointestinal inflammation, just colonic inflammation, but many of these extraintestinal manifestations are not exclusive to Crohn's disease. Whether it's aphthous ulcers, arthritis, about 40% of people will have arthritis, particularly the larger joints. It does tend to be correlated with extent of colonic involvement. So pancolitis will have more arthritis than just proctitis. It tends to be large joints and symmetric, bilateral, hips, knees, sometimes smaller fingers, sometimes spine, which tends not to go along with the pattern of the disease. So most arthritis will resolve if the colonic inflammation is under control, but that isn't necessarily the case with the spine. Uveitis, pyoderma gangrenosum, erythema nodosum, the neutrophilic dermatoses that can occur, and then primary sclerosing cholangitis, 3 to 5% of individuals with ulcerative colitis, particularly younger males, but not exclusively, and it tends to have a fairly dire prognosis, particularly since we don't have effective therapies, and those therapies which are effective for ulcerative colitis are not effective for PSC. We borrowed this pyramid from our rheumatology colleagues. Aminosalicylates are really the major pillar of therapy for ulcerative colitis. Pediatrics will use a good deal of nutrition therapy. I think that tends to be more with Crohn's than ulcerative colitis. We don't have therapies that are as effective. There is no role really of antibiotics that's been established in ulcerative colitis. There was one study of Cipro as a preventive for flares, weakly positive, and that hasn't really been taken up more broadly. While steroids can be effective, we'll use them just for short periods of time, and as long as we have sort of an exit strategy, what are we going to do as the next step? Ulceris is a budesonide delivery to the colon, as opposed to Entocort, which is budesonide to the ileum. It is can be effective, but weakly so, and not nearly as effective as prednisone. We've gotten away somewhat from azathioprine 6-MP, as about 20% of people have problems tolerating it, and turn more to the biologics or even surgery. So to review some of those in more detail, when we go to sulfasalazine, stumbled on in the 1930s really by Nana Swartz, originally for arthritis, and she found then that people with arthritis and colitis or colitis improved as well. And then we realized that about 30% of people have problems tolerating it, and we wanted to come up with better mechanisms of delivery of the mesalamine, the active compound, to make this more tolerable and fewer side effects. And so when we look at the different mesalamine preparations, these are all mesalamine, but different trade names because of different delivery vehicles. Mesalamine, which is delivered throughout the small bowel and colon, was really developed for approval for Crohn's, but didn't have 2 positive studies and has never been approved for Crohn's. Azicol, which is really delivered to the terminal ileum and throughout the colon. And then a variety of other compounds, asulfidine, dipentum, which we don't use so much anymore, as at higher doses it can cause diarrhea. Colazol, which is mesalamine with an inert carrier and a prezo as well. And then there are local deliveries. These are all mesalamine, so all really the same active ingredient, but using the trade names here just to delineate a different delivery system with Roasa, an enema, a formulation of 4 grams, and Canessa, a 1 gram suppository. And the enemas really do get up at least the whole left side of the colon. So a key question that we debate in taking care of ulcerative colitis is more better. And I'd say probably the best study was done with patients who had mild to moderate disease activity, placed on mesalamine at 2.4 to 4.8 grams a day. Those with the lower dose with mild disease was really equivalent, but for moderate disease there was about a 13-point gain of improvement at the higher dose compared to the lower dose. Not all studies have shown that. In fact, even the initial studies of mesalamine as Lialda, which has a special delivery system called MMX, 2.4 was equivalent to 4.8. We still often push it up to 4.8 for people who are not responding, but the data really suggests that that's for mild disease, that's not necessary, and it's more for moderate disease in patients not responding. And maybe something about the delivery system, as you can see here, not statistically significant, but those that got mesalamine as Azicol at 2.4 didn't do numerically as well as those with mesalamine at Lialda 2.4. For maintenance of remission, in terms of how often we should give these diseases, firstly, these are medications we should continue throughout and not just when someone's having a flare. We really want to, this was a study looking to see whether twice a day or daily mesalamine at the same dose was effective. When we started using these drugs as sulfasalazine, they were 4 times a day, and then studies with 3 times a day, twice a day were effective, and then the question was is there something specific about mesalamine delivered as Lialda that's different than mesalamines delivered as other medications? And it really seems here that with mesalamine as Azicol, you can get away just as well with once a day as you can for twice a day, and I think the upper limit here used was just 2.4 grams a day. Not surprisingly, if people don't take their medications, and it's particularly single males who do the worst. I guess once males get married, they tend to be kicked into line by their spouses and do better. But those who were adherent to 5-ASA therapies did much better than those who were non-adherent, with greater than 50% flaring within 20 months. And it's a very mild medication, very well tolerated, particularly the 5-ASA that's not mesalamine, not sulfasalazine. So with sulfasalazine, we do worry about anorexia, headache, nausea, vomiting, gastric distress, and infertility. Incident is as much as 20 to 30%. People can get a rash. People can get other things that are less common, like neutropenia, other things that we'll go over in a bit. Those are not entirely, but largely eliminated by getting rid of the sulfa and using the other delivery systems. There's problems still with some nausea, but that's rare. Abdominal pain, that's pretty rare. And we see this as well with the 5-ASA. But it is worth keeping in mind some of these uncommon adverse events that we do see. Most important probably is this paradoxical worsening of ulcerative colitis symptoms. Perhaps happens in about 1% of patients, not always at the start of medication. If you stop it, you'll see a difference if this is the cause in about 48, 72 hours. It's important to recognize sometimes it's in patients who have incomplete response to some of the other therapies. It's again, not common, but important to keep in mind so that you're not ascribing someone's worsening symptoms to their colitis as opposed to the medication. Other things that happen but are rare are pericarditis, pleuritis, hepatitis, pancreatitis, neutropenia, interstitial nephritis, arthritis, and alopecia. Even without the sulfa, they're much less common and important to keep in mind. So the next step for people who are not responding that we have to keep in mind is steroids. And as much as we try everything we can to stay away from them, they can be effective. And I think that we need to understand that we sometimes impose a burden of disease on our patients with this. So that when we, looking at this, and a similar study was done in Crohn's, that about half at 1 month came into complete remission, about a third have partial remission, and a little less than 20% have no response. But the problem is that at a year, only about a half are in prolonged response. Only about 30% of them are probably in histologic remission, and we're really pushing for that these days. About a fifth or a quarter become steroid dependent. So you can't stop them. It's got their own set of side effects. And about a third, or 29%, will go on to have surgery. So steroids are effective, can be used, but we try to really limit their efficacy. And again, budesonide as Ulceris is not as effective as prednisone, and not nearly as strong an agent. Azathioprine, as a mechanism of getting people off of steroid for steroid dependence, can be reasonably effective. In this study, as much as half of the patients studied were able to come off of steroids and be maintained on azathioprine. For 5-ASA, it's a lot less than that, and this wasn't with a placebo arm, so the likelihood of being able to come off of steroids and just be on mesalamine is limited. When infliximab came along in two studies, both the Act 1 and Act 2, clinical response was 1.7 to 2 times the placebo rate, which is good, but not really quite as good as what we had seen in Crohn's disease. It certainly helped be a steroid-sparing agent, and is an important adjunct. As we've gone forward with using these medications more, we understand that there certainly more is better. And as you get higher in your levels, you can see here you have a higher response. So typically for Crohn's, we're looking for a slightly lower level for the infliximab of 5 to 10, sometimes up to 15. These studies have correlated a much higher response, or higher levels with a higher response rate. And so we want to figure out how we can use antibodies and levels to optimize management. So when we look at a detectable anti-drug or HACA, human anti-chimeric antibodies, when we see if there's a detectable antibody here, and we switch to a different, well, first, if we just see here, if you increase the infliximab with antibodies present, your response rates are pretty low. If you change to a different anti-TNF, meaning the reason why you're losing response is that there's antibodies that have developed to infliximab. You go to a different anti-TNF, you can get very good responses. If the subtherapeutic concentrations, you can increase the infliximab and get a benefit considerably. Changing isn't necessarily a benefit, and often the first anti-TNF is the best, so that when you check concentrations, there was an impact on decisions in a high percentage of cases. Factors that influence, though, the PK of TNF agonists, important to keep in mind, not only anti-drug antibodies. Concomitant immune suppression, which we've used, certainly may have worked not because there's a synergy there, but in terms of an inflammatory impact, but just by raising the drug concentrations of infliximab. Low serum albumin concentrations increase drug clearance. A high CRP, there may be a broader sort of sink or targets for the anti-TNF antibody. High body size may increase drug clearance, and gender, with males having high clearance. So if you're seeing someone in the hospital with a high CRP with ulcerative colitis, high flare, obese, male, guy with a very low albumin, it would be reasonable to start up at a higher dose at 10 milligrams per kilogram rather than starting at the lower dose. Vedolizumab is the next agent that has come along that can be quite effective, particularly for ulcerative colitis, perhaps less so for Crohn's. You can see a difference in as little as 4 weeks, but it really takes about 10 to 12 weeks to get the full response, which can be much more robust. And what's important here is that there's nothing necessarily sacred about the 8-week infusion cycle, and there may be some benefits, particularly if someone's starting to lose the benefit after 6 or 7 weeks. Shortening the cycle can be effective. As I mentioned before, there was a similar SONIC study done in ulcerative colitis. This success study, as it was called, has shown similarly there's a synergy, and this may be acting not because azathioprine has a different mechanism of action, but maybe that it improves the infliximab levels and improves outcomes overall in terms of dual therapy. When we look at what else is coming down the line, we have, or what we have available for ulcerative colitis and Crohn's, we have infliximab and adalimumab. Golimumab is just indicated for ulcerative colitis. Certolizumab, just Crohn's. Stelara currently is just Crohn's, but vedolizumab is for both ulcerative colitis and Crohn's, and perhaps more so. With these cell adhesion molecule antagonists, there are several, particularly etrolizumab, which is coming down the pike in studies. So when you look at natalizumab is just alpha-4, and that interacts with the brain and the gut. Vedolizumab is alpha-4 beta-7, which is just the gut, and etrolizumab is beta-7. So we'll see the advantage of vedolizumab is it seems to be more selective and less possibly systemic effects. Now, we really do try to push towards mucosal healing. When we look at the extent of mucosal healing, not surprisingly, there's a relationship between better healing and more likelihood of going on to develop or need colectomy. And other complications as well. So really pressing for histologic remission is a reasonable target, or at least close to it, in ulcerative colitis. One of the premier or main concerns we have in chronic ulcerative colitis is ongoing inflammation and the risk of dysplasia leading to colorectal cancer in ulcerative colitis, and those risks that are increase the risk are a longer duration of disease, greater extent of disease. So just proctitis or proctosigmoiditis probably doesn't really have an increased risk or hasn't been demonstrated, but active disease, pancolitis, is a greater risk, even if it's just microscopic. Increased activity, not surprisingly, a mass, stricture, presence of dysplasia, but importantly, a family history of colorectal cancer. Primary sclerosing cholangitis is a concern and a risk factor for initiation of, sufficiently to initiate a colonoscopic surveillance at the time of diagnosis. And then presence of pseudopolyps, even if the pseudopolyps themselves are not risks for cancer in themselves. It suggests that there's a process going on in the colon that is a risk. Possible is younger age of diagnosis and backwash ileitis as well. Some of these earlier studies suggesting that there's as much as a 2 to 2.5% risk of developing colorectal cancer annually may overstate the risks, particularly recently, or maybe we're more aggressive at getting disease under control, or people end up getting colectomies sooner, and so that they aren't going on to develop cancer. Some of the more recent studies are a little bit lower than the older studies. When we look at dysplasia, one thing that's important to recognize is that a high percentage of dysplastic lesions, really about 90% plus, can be identified on white light, and particularly now with high definition endoscopy, we do a much better job. But at least here's some studies using white light, and you can see most of them, except for this one, which was the smallest, showed a significant benefit over chromo. Chromo endoscopy, where you spread some either methylene blue, indigo carmine, and you're looking for two things. This helps with picking up more polyps, and it also helps in terms of picking up the pit patterns, how the dye is taken up, and it lets you do a surveillance on a broader area rather than just these random biopsies, which I think are less helpful, and certainly that idea is reinforced in these studies. The issue about dysplasia that's important to recognize is it's not necessarily someone has low-grade dysplasia, then eventually goes to high-grade dysplasia, eventually progresses to cancer. Low-grade dysplasia itself can be a marker of high-grade dysplasia or cancer. Cancer, the risk is at most 20%, possibly much less than that, but the older studies suggest it's higher, and progression to high-grade dysplasia can be much more like 30 to 50%. High-grade dysplasia, the likelihood, it's a marker of likelihood of cancer at that time. So as much as 50% of people with high-grade dysplasia are going to have cancer. So there is consensus about colectomy for high-grade dysplasia. Some people would suggest that low-grade dysplasia is as predictive as high-grade dysplasia, but there's some controversy about whether low-grade dysplasia should be a reason for a colectomy. I think it really depends on dividing that up better, so that are you really identifying a single focus, or is it multifocal, and a variety of other factors like that come in and are important. So the guidelines are that screening colonoscopy should be performed with ulcerative colitis patients about 8 to 10 years after onset of symptoms. Patients with extensive colitis, left-sided colitis, or negative screening colonoscopy should begin regular surveillance within 1 to 2 years after this 8 to 10 year mark. Some people suggest after 15 years for left-sided disease, but the current guidelines are really after 8 to 10 years. Surveillance examinations after 8 to 10 years should be performed every 1 to 2 years. After 2 negative examinations, the surveillance examination could be performed 1 to 3 years, but once 20 years has come, really it's every 1 to 2 years. And it varies from the British guidelines, which say that if the histology is normal, the screening interval can be extended up to 5 years. As I mentioned, patients with PSC should have surveillance colonoscopy at the time of their initial diagnosis, and then yearly. Patients with proctosigmoiditis have little or no risk. So those patients who do need to go on to surgery, the mortality is quite low, particularly at centers with more experience. Once people have had a J-pouch, and it's really a 2-stage that's recommended, they should expect about 4 to 10 stools in a day. Impotence is rare, but can happen. Pouchitis, as one episode, happens as much as 50%, but chronic pouchitis can happen in 10 to 15%, and perhaps even more than that. Small bowel obstruction, decreased female fertility is important, and a pouch vaginal fistula or other complications we're concerned about that can happen frequently. Other complications of pouch surgery is really short-term with sepsis. Leakage can sometimes go a little bit longer, and incontinence can be a longer problem. But we do worry about these other factors as mentioned, and particularly female infertility, and something to be alert to prior to surgery. When we look at outcomes over a longer period of time by age, there can be some problems, and here's an area where pelvic floor physical therapy can be helpful to try to reduce nocturnal seepage, and there are a variety of other techniques, and keeping in mind dietary interventions, caffeine, low sugar intake, which influences fluid excretion through calcium activated chloride channel, and other manipulations such as FODMAP diet have been shown to be of benefit for individuals with pouches. So we have a few questions just to go over briefly to review. So which of the following is not effective for maintenance of remission for ulcerative colitis? One is mesalamine, prednisone, vedolizumab, golimumab, or infliximab. And the best choice is B, prednisone. While prednisone can be effective in achieving control of an acute flare of ulcerative colitis, it is not effective for maintenance of remission. As much of a third of patients will become steroid dependent once steroids are initiated. So while improvement in clinical conditions will occur in 2/3 of patients with UC, healing can be achieved with only about a third of patients. The other medications all listed there are indicated both for getting control of an acute flare as well as maintenance of remission. Question 2, which of the following is an indication for a colectomy in individuals with ulcerative colitis? A, more than 20 polyps. B, more than 5 adenomas with low-grade dysplasia. C, high-grade dysplasia. D, steroid dependence. And E, diverticulitis. Now, all of them potentially could be, but the best choice is C, the patients with high-grade dysplasia. They have an increased risk of concomitant colon cancer. If you have an adenomatous polyp that's clearly a discrete polyp, even if it's more than one, it's sometimes difficult to tell, and they do require close surveillance, but you can do a polypectomy, and the patient does not require colectomy. Inflammatory polyps require close surveillance because that can be a risk factor for dysplasia, but it's not an indication for colectomy in itself. Diverticulosis is not an indication, and diverticulitis in itself is not necessarily an indication unless it's more severe diverticulitis that requires surgery in itself. But the concomitant problem with ulcerative colitis, which isn't common, doesn't mandate colectomy in that case. And then question number 3, which of the following would be best recommendations for a patient who had responded well to infliximab, lost response for treatment of ulcerative colitis when treated with 5 milligrams per kilogram, which was found to have very low level of infliximab trough level and a high level of antibodies to infliximab? Would you increase the dose of infliximab, shorten the interval of infliximab, switch to adalimumab, switch to vedolizumab, or add prednisone at 40 milligrams? The best answer would be C, switch to adalimumab, because the patient had had a good response to infliximab, and you have an answer why the patient lost response. It's because the patient had developed antibodies. So increasing the dose to a higher dose or shorter interval may get you a little bit of a better improvement for a very short period of time, but it's not going to be more durable. You're not likely to increase the level of infliximab, as the antibodies developed to infliximab will counteract the attempt to increase the levels. Switching to vedolizumab would be recommended if the individual had an adequate level of infliximab and was not responding, so you'd want to try a different pathway, but I wouldn't jump to that yet and utilize a different medication, as you don't want to run through things too quickly. And the same therapeutic pathway is reasonable in this case, as the reason of loss for response was the development of antibodies to infliximab. So in sum, mesalamine is effective for controlling acute flares and maintenance of remission in ulcerative colitis. Steroids should be used sparingly and are not for maintenance of remission. Steroid-sparing strategies should include biologics. Therapeutic drug monitoring of biologics can improve patient outcomes, and management of ulcerative colitis includes routine surveillance for colon cancer beginning after 8 years of disease, or if with PSC at diagnosis. Thank you very much.